transplant, whether mother, father, sister or brother having a transplant, among this we can HLA we have matched, but in renal transplantation HLA may not be so much important, because many unrelated transplant or even in the husband-wife transplant or in a swap transplant is going on beyond the HLA matching. But preferably, if the more match, the chance of rejection is less and the patient survival, graft survival is definitely better in the non-match subgroup. So even in certain cases where the HLA match is there but cross match is positive, should we stop the donation or should we stop the renal transplantation? No. So with the advent of some new drugs, new protocol, some desensitization protocol is there. So we can take this donor with some prior treatment. So what is desensitization? A medical approach to reduce the harmful antibodies in the recipient bloodstream, or essential for the patient with the donor specific antibodies which may cause transplanted kidney rejection. Common in cases where the patients have developed the donor-specific antibody from the prior pregnancy, blood transfusion or previous organ transplantation. And why this is needed? Because immune system recognize the transplanted kidney as a foreign and leading to a potential rejection. And desensitization modifies the immune system to reduce the risk even with the pre-existing antibodies. So you have to take care of these things, donor-specific antibody. So how this desensitization can be done? There is a various methods, and many centers actually follow the different rules, either in combination or in singly. There is a plasmapheresis, IV immunoglobulin, rituximab, bortezomib, these are things, and they have actually acts in the different target level. In the plasmapheresis, they removes the antibody from the body. In the immunoglobulin, neutralizes the antibody. In the rituximab, depletes the B cell production in antibody, and bortezomib that target the plasma cell that producing the harmful antibody. Who are the benefit? The desensitization, that is patient who are highly sensitized with a high level of pre-existing antibodies and making it hard to find a compatible factor. So few lines about the immunosuppressives. How the immunosuppressive we actually use for the kidney transplantation. That is, first things when the operation date is finished, that is finalized and recipient and donor is already ready, then we started the immunosuppressive. They are called induction, and there is a two type of induction. One is a depleting and non-depleting induction. That is, in case of unrelated transplant or the challenged transplant or second transplant, or even in the mutation related transplant swapping, we actually give ATG. There are different type of ATG, and what is the purpose of these things? We actually reduce the immunosuppression and to address, that is, the immune reaction, to reduce the immune reaction. And in a case of less challenging cases, that is where the HLA match, or there may be some patient where there is a less challenge, there is a live related donor is there, matched donor is there, then we can give the basiliximab. And after the induction, after the post-transplant, we can continue in the maintenance immunosuppression in the form of corticosteroid, calcineurin inhibitor in the form of tacrolimus and cyclosporin, and some antimolabolide that is called mycophenolate mofetil and azathioprine. And in certain group of patients where actually calcineurin inhibitor may not be successful or maybe contraindicated, we can use also sirolimus or everolimus. So what actually the surgical procedures? Surgical procedures is the pre-operative care. The patient kept fasting, need proper hydrations, their bowel movements and bowel clearing should be ensured, and usually anticoagulant should not be given. And the day of operation, patient should have adequate hemodialysis or peritoneal dialysis, whatever in the form. The thing is that patient should be fit for the anesthesia. And preoperative care regarding the fluid balance, patient remain actually minus fluid level, because we have to give much more fluid in the OT. So patient should not be over burdened with the fluid, or there must not be any hypertensive crisis at the OT. And second, adequate dialysis is important, maintaining the EPO and IV iron, because hemoglobin should be maintained around 11 to 12, and patient should not have a fever or any active infection prior operation. And regarding the transplant surgery, because actually done by either urologist or in the CDVS surgeon or in a combination team or some specific transplant surgeon, dedicated transplant surgeon as well, because first part is actually donor nephrectomy, and then second part is the nephrectomized kidney should be, retrieved kidney should be placed in a recipient pelvis. So a new kidney is placed on the lower right or left side of the abdomen, where surgically connected by near blood vessels. Placing the kidney in position allows it to connect easily to blood vessels and the bladder, and vein and artery. The new kidney should be attached with the recipient veins and the artery. So what happens actually in the pelvis, there is a space. So in kidney there is a three important structure. One is the renal artery, one is the renal vein, and one is the ureter. So artery should be connected with the iliac artery or corresponding arteries. Vein should be the iliac vein, and the ureter either implanted in the bladder. So this is the actual surgical procedure by way the kidney transplant is actually taking place. So this is the procedures. I'm not going to details like incision, exposure, kidney mobilization, and the kidney procurement, and steps like all the surgeries like general anesthesia, incision, exposure, urinary tract preparation, implantation, and urinary tract anastomosis, and ultimately the closure. So if you see, this is the retrieved kidney, and some fat part is actually taken out, and this kidney with the renal vein, this is called hilum, and this is renal artery, and this is the ureter. All the three important structure should be placed here, and this actually should be connected. That is the abdominal aorta, common iliac artery, and this is bifurcation. You can put in the common iliac artery, common iliac vein, and there is the ureter that actually implanted in the bladder. So this is actually the right pelvis area. This is the ideal place for the renal transplantation. Regarding the post-operative care, you have to be careful about your maintaining of your fluid status, maintaining about your prophylaxis like septum, valves, and also the giving the valve ganciclovir. You have to be very careful about your catheter removal. You have to be careful about the daily drain out of it, and you have to also consider about whether graft functions, because initial 1 or 2 days kidney is functions and actually come down to a normal baseline level within 2 to 3 years with the adequate urine output. So we have to be very much careful about the medication, lifestyle, and infection prevention. But patient is actually discharged within usually within 2 weeks, and even in the earlier as well if everything is going fine. But even after discharge also, patient should be careful about the adequate medications like immunosuppression, like the tacrolimus level, whether any immunosuppression related toxicity is there. So as a physician, as a renal physician, or any primary care physician who actually taking care of this patient, very much careful about all the aspect of the, because this type of patient basically they're immunocompromised, they are very much prone for infection. So they should, or they maintain the adequate protection by making a mask. They are not actually very careful when there is a fever, or they should consult the either renal physicians or in a primary care physician where there will be any problem like these things, because the drugs that actually they have taken, that is the tacrolimus or MMF or prednisolone, that has some drug to drug interaction. So many of the drugs they cannot take. So as a primary physician, they should be very much careful about the drug dose, drug selectivity, and the drug choice for addressing any kind of fever, any UTI, or any disease that is associated with it. So there must be some monitoring of some important part. There is a food, there is a temperature, whether fever is there or not, adequate urine is there or not, is there any nausea, vomiting, or any tremor, because all of the important part that can address a particular complication of the disease. And what is the common complication of this post-renal transplantation? The first important and most dreadful combination is the delayed graft function. That is, the creatine is not come down to the baseline level, or even in the come down, it is a come down after some days or weeks. So the kidney is being transplanted is not actually adequately, nephron is there, or some insult is there in the form of the acute tubular necrosis or ischemic nephropathy, or some surgical complication is there. We have to address to take the initiative in the very early. So first is the delayed graft function, is known as acute tubular necrosis. This is the transplanted kidney does not start working in the right way, and primarily non-functional. This is a rare complication occurs when transplanted kidney never starts working. So sometimes if you fail to choose the right kidney, that is I have just discussed, that is where the score is more than 7 to 12, even in the disease not organ, in the non-heart beating donor, kidney may not be open up. So this is the total failure. So patient is to be start dialysis even in the post-transplant immediately. And last, there is a next important part of the complication is the infection, because as the patient is immunocompromised, there are a lot of infection, and there is a atypical infection is very common in case of this disease. So whenever the patient, and sometimes the patient may not have enough fever, because there are low count sepsis is very common in this group of patient. So even in the small symptoms should be addressed adequately, and that should be taken care adequately. That is, immunosuppression medication prevent the rejection, and antibiotics are taken to prevent the infection in a right way, in right need-based manner. Then another important thing, the surgical complication like the ureteric stenosis, or there is no urine output, or urine output is there, there is much more in the drain. So there must be some ureteric leak, there must be some diversion of the urinary there. So urine is actually accumulated in the abdomen. So we have, so there will be drain creatinine will be much more, there will be much drain will be not be reduced adequately as we expected. So that actually lead to the ureteric leak, or maybe a ureteric stenosis, hydronephrosis, there may be a renal artery stenosis, there may be a lymphocyl as well, or transplant artery thrombosis that may present with, there is a accelerated hypertension or some hematuria or in a different way. So in these cases, patient need to be consult with either transplant physician or primary care physician or medicine people, or even in the surgical people, or the team for whom actually he has been transplanted, to address these things and to take necessary actions immediately.